אוקיי, אז אנחנו נתחיל. ברוכות הבאות וברוכים הבאים לפורום הקליני מחקרי בנושא CFS ופוסט קורונה. האירוע היום יהיה באנגלית, אז אני ברשותכם עוברת עכשיו לאנגלית. Welcome everyone to the second meeting of the Israeli Research and Clinical Forum for CFS and Post Covid. My name is Ronnie Hakaran, and together with some incredibly dedicated but fatigued patients, I lead CFS Israel. We started this forum with the generous support of the Keren Bria Foundation to encourage people from the medical community in Israel to learn more about post-infectious diseases and hopefully work with us to make Israel a better place for people suffering from these diseases. I'll be really honest with you. Hope can be a really difficult thing to come by when you have a post-infectious disease. But seeing all of you here today is giving us a really, really good dose of hope. So thank you so, so much for taking the time to listen to this lecture today and to listen to us more generally. If you'd like to speak to us patients a bit more, after the lecture, we'll stick around. If you want to chat about cooperating, learning more, anything like that, we'll be here. Also, feel free to just drop us an email if you want to chat about anything at all. On to today. We are extremely, extremely honored and excited to have with us today Dr. Menanie Hoppers of the Bateman Horne Centre in the United States. She will be taking you through the essentials of diagnosis and management for CFS, post-COVID, and other comorbid conditions. Dr. Hoppers is a practicing physician, board certified in internal medicine and pediatrics, with 30 years of clinical experience. As a part of Dr. Hoppers' work with the Bateman Horne Centre, her focus is dedicating to serving patients with complex multi-system diseases such as CFS, dysautonomia, and other post-infectious syndromes like long COVID. Dr. Hoppers is also the co-founder and chief medical officer at Physicians Quality Care. She will be speaking for 1 hour, and after that we'll have roughly half an hour for kind of questions and a discussion. So please keep your chunky questions to the end. If you have any kind of clarification questions during the lecture, she'll be happy to take those. So just pop them in the chat or raise your hand and we'll try to get to those. Also, please know that this session is being recorded for the benefit of the patients and others that couldn't make it today. We will send you the recording afterwards, together with kind of additional learning materials for those interested. Thank you so much, Dr. Hoppers, and thank you, Talia from the Bateman Horne Centre, for being with us today. We are all yours.
All right, I'm going to share my slides here and see if I can do it without a big, there we go. Okay, is everything looking good on your end?
It's on mine. Does anyone have any complaints? Perfect.
Okay, it was looking good, I think. Okay, so thank you so much for the opportunity and invitation to speak to you today regarding ME/CFS, long COVID, and their comorbid conditions. This is a subject that is very near and dear to my heart, and I so appreciate those of you who are in attendance because it means you are an interested physician or healthcare provider, and we need more of you. I'm going to talk today about some off-label use of various medications, and I will let you know about that as they come along. BHC, the Bateman Horne Centre, does contract with various pharmaceutical companies to carry out phase 2 and 3 clinical trials, and I won't be discussing any of those today. And just as a quick disclaimer, I am going to tell you sometimes about some things that are of practical use. I'm not endorsing them. I have no financial benefit from that. It's just to help you have some tools. I hate to go to a lecture and I hear generalities, but I don't have anything practical to go home with. So I want to provide that for you today. So the Bateman Horne Centre is a 501c3 nonprofit organization. We provide clinical care, conduct research, and educate both patients and providers regarding ME/CFS, long COVID, and their comorbidities. In today's talk, my real objective is to help each of you feel comfortable recognizing, diagnosing, and treating individuals with ME/CFS and long COVID. I will do this addressing some of the more common problems that occur with this illness and kind of show you how I break things down and how I approach a patient. Myalgic encephalitis chronic fatigue syndrome is also known as ME/CFS. It is a chronic, debilitating, multi-system illness. It is characterized by central and peripheral nervous system involvement, dysfunction of the immune system, with some parts being overactive and some being underactive. There's a dysfunctional circulatory system, and there's impaired cellular metabolism with a low threshold for converting from aerobic to anaerobic metabolism. The mechanisms that cause ME/CFS are not completely understood, but there often is an inciting event that triggers the immune system, which then responds in a dysfunctional way. It is thought to be post-viral or post-infectious in most, but not all cases. And we are starting to call the ones that are associated with infections as infection-associated chronic conditions. Many viruses, many bacteria have been associated: EBV, West Nile, of course, SARS-CoV-2, Borrelia burgdorferi, and Giardia are some, just to name a few. About 10% of people with COVID infection develop long COVID. And studies have shown that up to 50% of these people meet criteria for ME/CFS. I read a recent article in, it was Nature, that said that there are 400 million people in the world with long COVID. In addition, however, ME/CFS can be triggered by other events. It can be a concussion, whiplash injury, surgery, toxin exposures, pregnancy, even vaccinations. Things that trigger the immune system seem to be the underlying theme there. Oftentimes, however, the inciting event is never identified. Sometimes you'll have a patient who says, since I was in junior high, I felt like this, and they can't remember what happened. I also have patients who have subclinical issues. Recently, or not so, is a year or so ago, I had a patient, and she came in, she was in her 30s, and she had sudden onset of POTS, postural orthostatic tachycardia syndrome. One day she started fainting. And she fainted every day for a month or so, and she came in and saw me. And I could not find anything that seemed to have triggered it. I asked, have you had COVID? No, I have not had COVID. This was in the middle of a lot of COVID infections. And, have not had COVID, but she had not been vaccinated. So I was able to check antibodies, and she indeed had very high levels of antibodies. So, she had no idea that something had triggered this. So don't let the lack of a known trigger be a reason you don't diagnose ME/CFS if the person meets criteria. That is not uncommon. That is not required. So how common is ME/CFS? So there's a lot of data to be looked at, but before the pandemic, ME/CFS had a prevalence of around 1% in the population. In the US, this was 3 million people. So then we had COVID. And as I said, there are now 400 million people worldwide with long COVID. And again, 50% of those in studies have been shown to meet criteria for ME/CFS. So you can imagine the increased numbers we now have with patients with ME/CFS. And the point of that is we need providers who will help these patients. Before COVID, it's just almost impossible for someone to provide a helper, to find a provider who can help them. Now it's just overwhelming for patients. So again, I really appreciate that you're here trying to learn about this disorder. So diagnostic criteria was developed in 2015 because we don't have a convenient identifiable biomarker to identify a person with ME/CFS. And there are core clinical criteria that are used to make the diagnosis. So the first criteria is that the person must have substantial impairment of normal function. So you have a person who was functioning normal and was healthy, and now they no longer can function in the same capacity. This is accompanied by fatigue, and this must have lasted more than 6 months and not be relieved by rest. They must also have post-exertional malaise, and we'll talk about that in a minute in case you're not familiar with that. Non-restorative sleep is another of the core clinical criteria. Then these symptoms must be present 50% of the time, and of moderate to severe severity. In addition, they must have one of the minor criteria, and these are cognitive impairment and or orthostatic intolerance. Most of my patients have both of these, but you only have to have one. This is a remarkably disabling illness, with 75% of people that cannot work or require work accommodations of some sort, or school if they're young. 25% of people are homebound or bedbound at some point in their illness. And I want to remark too that anyone can get this illness. Children get this illness, adults get this illness, all races, all people can have this illness. No one is spared. So today, what I'm going to focus on is post-exertional malaise, dysautonomia, and mast cell activation syndrome. These are three of the more common comorbidities that occur with this illness. There are many more that I have listed, but when I approach a patient, I try to find what is the most disabling factor in their life. Is it their orthostatic intolerance? Is it their MCAS? Is it their post-exertional malaise? Or is it their sleep impairment? They all have an impact, but oftentimes the three that I'm going to talk about are the ones that have the most impact. So that's where I start. So this is a post-exertional malaise. This is an image that a person gave me permission to put on my slide, and I use it because I think it really just gives you a quick picture of what the person feels like when they're in post-exertional malaise. It's a pathognomonic feature of ME/CFS and one of the core criteria for its diagnosis. So post-exertional malaise is also called PEM. So if I use that, you'll know what I'm talking about. It has been defined as worsening of a patient's symptoms, as well as worsening of their level of functioning following even small amounts of previously tolerated exertions or stressors. These can be physical, cognitive, emotional, social, or environmental. And we call them stressors, but as I was doing this talk, I thought about it. And what they really are is just, it's a way that we use energy. All of these things are ways that we use energy, and that's kind of the unifying thing there. PEM, in addition, is often delayed. So when most people exert themselves, let's say you go outside and you decide to run a mile, and you come in and you are out of breath, and maybe your heart's racing a little bit, and you sit down, and in 30, it depends on how healthy you are. In 10 minutes, you may have recovered, or it may be, an hour you recovered. But in PEM, the recovery time is out of proportion. Sometimes recovery takes days, weeks, months, and I have even had people who have had, thus far at least, a permanent reduction and have not recovered from PEM. It's often delayed and can occur 12 to 72 hours after the exertional stressor as well. So this is kind of confusing for people. They do something and the repercussions don't occur for 2 or 3 days. So sometimes that can make them hard to understand cause and effect. So that can be very confusing. So again, on to the triggers. So what can trigger post-exertional malaise? Again, things that cause us to use energy. A person with myalgic encephalitis, chronic fatigue syndrome, has kind of what we call an energy envelope, and each person's energy envelope is different. A person with severe ME/CFS has a very small envelope. A person with mild ME/CFS has a larger envelope. So physical triggers could be exercise for someone with mild ME/CFS, or just walking to the bathroom if you're severely ill. I have a patient recently, and his was cognitive activity, actually. So let me get to that first. So cognitive activity can be things like studying for exams in a more moderate patient, or sending a couple of texts for the more severely ill. So I have a patient, he's 15 years old, and he has long COVID, and he's severe. He is bedbound other than going to the bathroom. And he can't do much. He does do homeschool a little bit in his bed, but he doesn't do much with friends as far as conversations. This seems to be distressing to him to hear what they're doing, so he doesn't do that much. But a couple of months ago, he thought he'd text a few of his friends, And he ended up in post-exertional malaise, and his symptom was that he couldn't swallow solid food. There wasn't much left for him not to be able to do, but that was his episode of PEM. So it just kind of depends on the baseline ability of the person. Emotional triggers can cause it. And unfortunately, it's not just negative emotions, it's positive emotions. The birth of grandchild may put someone into PEM. Social triggers, conversations, visits with family, parties, things like that can be exhausting for people. Environmental triggers, so bright lights, noisy environments, smells, walking through a shopping mall. When our body has to process sensory input, that requires energy. You don't think about this when you're normal and healthy. You can do what you want to do. You don't think about the fact that chewing food takes up energy. But all of these different things take up energy. Life takes up energy. So people who were once healthy and could do what they wanted to do essentially are now finding that just normal everyday activities can trigger post-exertional malaise. So this is very confusing and very distressing. So here's a study, and it just illustrates the prolonged recovery time. So these subjects were divided into patients with ME/CFS and healthy individuals. And they gave an exercise challenge. And what they found is that people with ME/CFS took an average of 2 weeks to recover from that exercise challenge. And the people that were healthy took 2 days. And you also have to consider that these weren't the severe patients. These were the more mild to moderate patients who were able to come in and do an exercise test. So this study looks at cognitive changes in people with post-exertional malaise. And what they did is, again, healthy subjects versus subjects with ME/CFS. And they did cognitive tasks, and then they gave them an exercise challenge, and then they repeated those same tasks. And what they found is that in healthy individuals, they improved scores. They exhibited learning, whereas people with ME/CFS had a reduction in their scores. In addition, they did PET scans, and they found increased brain activity in the patients with ME/CFS. And the magnitude of that brain activity correlated with the number and severity of post-exertional malaise symptoms in the coming days for those patients. So normally when I do a talk on PEM, I go all through the pathophysiology, and I like to do that because this is an entity that for some reason people really have a hard time wrapping their brain around. A lot of times people are assumed to be lazy, assumed to have some secondary gain in not doing activity. And so I like to show that there is indeed something terribly wrong in their pathophysiology. And I won't go through all the studies, but what I did do is do a summary. And what they found is that people who are in PEM have a reduced aerobic capacity or ability to increase energy or to create energy. They are unable to utilize oxygen in the periphery. There's a problem with extracting energy at the tissue level. There's a reduction in mitochondrial enzyme activity, and there's muscle damage that has been shown during post-exertional malaise. There's amyloid-containing deposits, and this was done with biopsies, actually. The other tests were through 2-day CPET tests. What they found, just real quickly on the 2-day CPET test, is normal people, deconditioned people, and people with chronic illness, including cancer, multiple sclerosis, COPD, CHF, pulmonary, those were all used in the study. So they could come in, do an exercise test. Here's the results. Here's how much energy they can produce. Then they come back on day 2. They do the same thing. They can produce the same amount of energy. People with post-exertional malaise and ME/CFS are unable to reproduce the same results that they did on day 2. Again, illustrating that this is not something that's just in the patient's head. If I was going to make up something in my head, this would not be what I would come up with. So how does this translate into what the patient is experiencing? So I want you to think about this a little bit. So the people who are listening who are healthy, When you exert yourself, whether it's through going to the gym and exercising really hard, or you have a really hard time at work, you've got a lot of things going on, maybe it's a holiday and you're having company and you're having to really do a lot more things than usual, and you're pushing yourself to get things done. I want you to think about what it's like when it's over and what your recovery is like. What happens? Is it a day that you're tired? That kind of thing. So compare that to how I explained to you what happens in PIM. So with PIM, you do have extreme fatigue. It's extreme fatigue, fatigue that may last for weeks or even months. But they also have other symptoms. They'll have worsening of their baseline symptoms. So if it's a person with ME/CFS that have headaches, their headaches get worse. They become more intense, longer lasting. They may develop a new nature of the headache. They may develop a tension headache in addition to their migraines. Their GI effects become much worse. Their sleep disturbances are much worse. People with ME/CFS have a lot of insomnia and non-restorative sleep. But when they have PIM, they often describe feeling wired but tired. They'll say, my cognition is so bad, I can't read a book, I can't follow a TV program, but I can't sleep. So I lie there with my brain unable to be turned off, utterly miserable, but I can't fall asleep. Others, however, will experience hypersomnia. I have had patients that will sleep 2 or 3 days. They'll get up and go to the bathroom. They might eat something, but that's it. They just go right back to sleep. They also experience flu-like symptoms. I call this a low-grade flu. It's not, a fever of 103. It's more like 99, 100. They'll have swollen lymph nodes, sore throats. They frequently, in the beginning of their illness, will go to urgent care, primary care, the ER, thinking they have the flu or COVID or strep. Their tests are almost always negative, and eventually they figure out that that's not the problem, but they feel sick. They also have worsening of their cognitive symptoms, just more brain fog, more difficulty concentrating. Again, I've had people say, I can't even read a book when this is going on. Their orthostatic intolerance gets worse. Patients frequently become bedbound while they're ill and have frequent or have difficulty performing ADLs or even communicating. Full disclosure, I have a child with ME/CFS. She developed ME/CFS when she was 10 years old. And I have learned with time when she's in PIM, I don't talk to her. I take her food and I wave at her. And if she needs something, we'll have minimal conversation. But I've learned that she can't communicate with me. That just makes her feel worse. So clinical implications of PIM. So clinicians that have been treating ME/CFS for years have observed that continued and repeated episodes of PIM is associated with a worsened long-term functional prognosis. Repeated episodes of PIM or a particularly severe episode of PIM can result in worsening of an individual's baseline and can do so permanently. It's been postulated that these pathophysiological responses that are taking place may accrue over time and leave permanent injury to the neuronal networks. And this has been backed up by observational studies. In 2009, Dr. Jason, and this is the guy who came up with the theory of the energy envelope that I talked about earlier. So he took a group of patients with ME/CFS and he had a nurse coach them on pacing. And they did that for a year, and he came at the end and did surveys and determined who could pace successfully and who was unable to. Divided them into those groups, and what he found was that there were significant improvements in physical functioning and fatigue severity. This highlights that activity pacing and energy conservation is an important and effective intervention to achieve stability. And this is good news. So how do we determine if a patient is experiencing PIM? So what I do is I just think about what's the definition of PIM. And again, how does this differ from normal exertion in people who are healthy? So again, compare yourself again the last time you did something really exertional and ask these questions of yourself. Did it take you longer than 24 hours to recover from your exertion? That's kind of a key question. In addition, did you have physical symptoms? Did you feel like you had the flu after you did this? Did you literally get a sore throat and swollen lymph glands? Sometimes people do get aches. If you go work out at the gym, you're going to get some muscle soreness from the lactic acid that builds up. But do you have muscle pains, joint pains, headache, light sensitivity, sound sensitivity, sore throat after exerting yourself? Do you have cognitive symptoms that are worse? Frequently, again, people will have worsening of their brain fog. Do you have push crash cycles, or do you pay for it? That question is gold. A lot of times I'll ask a patient, do you feel like you push and crash? And you can see the recognition on their face. Sometimes that really seals the deal for me when I see how they react to that question. Are symptoms sometimes delayed? I'll ask my students, what happens to you after exam week? And they'll say, well, for a week I'm out, I'm done, and have to rest to recover from that. Are the symptoms delayed after the activity? Are your sleep disturbances worse? And are you less able to do activities that you are normally able to do after you exert yourself? So if I've determined that the patient does have PIM, then we want to talk about pacing. There's different ways to pace, and each individual responds differently to the different methods. And so I'm actually going to go through these a little bit, and you're going to get the slides, you're going to get the information. So don't worry too much. Don't just get hung up. I would like you to pay attention to the general concept, and the details will be available to you. So the first thing I like to do is I want to explain to them what PIM is, and explain to them what their experience is indeed real. It's not their imagination. I want them to understand the cause, and I want them to understand what the repercussions of PIM are. I feel like this is apt to help them be more invested in pacing, and so that they can be helped. Remember, and just think about this, it's very hard for a provider to understand post-exertional malaise. It's hard for people to wrap their brains around that. I try to imagine what it's like for the patient to understand that. However old the patient is, if they're 30 years old, and for 30 years they've been able to do what they want to do, and then fairly suddenly everything's changed. They can't, some people are athletes. They may be going to the gym every day. They may be runners. And now all of a sudden they run and their body is not doing what they're used to it doing. It's like their body's kind of betraying them. So this is hard for them to understand, and I can't imagine how difficult it must be for them. So when they come in, again, I give them resources, I give them educational resources, because after I talk about it, I'm sure they're going to go home and go, wait, what? And want to have more information. So I try to give them resources and just talk about it. At the visit, I do pacing modifications, because if I have them come in and I don't do anything at all, I don't respect modifications, then that's not going to convey what I want them to hear at this visit. So I have a lamp in the room. I don't have the overhead light on. I have a zero gravity chair. I try to make their appointments later in the day. When I can do telehealth, I do that. I support them with any disability or accommodation paperwork that they need for work or school. So then I ask them to utilize task modifications. Try to be creative. Use a shower chair. Sit instead of standing when you're doing your laundry. Use online services, food delivery services. Look at your priorities. What can you eliminate? I tell people this is kind of cool. The one cool thing, eliminate the things you really don't want to do, the things that you do out of obligation that aren't really necessary, don't. You can let those go. Encourage frequent rest breaks. I have one patient, she's retired, so she was able to do this, but she takes a day in the middle of the week that's strictly rest. She also, every day, 4 times a day, she takes 20 minutes and she lies down, puts her feet up, puts an eye mask on, and tries to do meditative breathing and just takes a rest. Just doing that has really made her feel better. She She can do a little more. And when she does things, she's able to enjoy them more because she feels better. This has been very empowering for her. And it was so gratifying to see this happen because, it's a difficult disease and hard for patients to have to deal with. And it's just really exciting for me to see her um, feel better about everything. So that was really nice. I have patients use timer for tasks. I have found, again, with my daughter, you start doing something and, everything's going well, you're having a good time, and you go, next thing you know, you go, uh-oh, I've gone too far. So I've learned to use a timer. I do a warning timer. So I have 5 minutes to kind of adjust, and then the timer that is, this is it, all done, doesn't matter, close up shop, so to speak. We limit screen time. I also tell people to recline or elevate your feet. Compression boots at the end of the day are nice. Also, reduce your sensory stimuli. Again, remember that takes up energy. So if you want to read a book, um, turn off the TV, go to a room that's quiet. Don't, if the kids are running around in one room and you can go to a different room, go to that room and don't have the TV on. So you're reducing all the other inputs so you don't have to use as much energy. So just be creative with those things. Then also we can do activity pacing. So I want to teach the patient, when you start to feel bad, when you start to feel a little short of breath, when you start to feel like the activity is difficult, you need to stop. Stop the activity. Don't push through. Try to lower your heart rate. Rest. Slow your breathing down. Lie down and get your legs up. If you have compression boots, these are really helpful. They're the compression boots that are automatic that will pump for you. Those are really helpful for some people. And again, reduce that sensory stimuli. You can also use your heart rate. Now, full disclosure, there are some people, I had a patient who said, I cannot do this. It's just driving me nuts to have to worry about that heart rate going off, and I don't like it. So this is not for everyone, but some people just have a hard time figuring out when they need to slow down. So they'll use this as a cue. And the first step in this is to determine your average heart rate, average resting heart rate. The way they do that is to take their heart rate before they get out of bed for 7 mornings, average that number, and now they have their resting heart rate. Then one way they can use that is every morning before they get out of bed, check their heart rate. If it's 10 beats per minute above that resting heart rate that they have determined, or if it's 10 beats per minute or lower, or lower than the resting heart rate. So, you have your resting heart rate of, say, 60. If you're 70 or above, or if you're 50 or below, then I call that a yellow light day, which means they need to try to see if they can take some rest, if they can cancel some things, just take it easy that day if at all possible. That's just a cue that you're not ready to do a lot. You can also estimate your anaerobic threshold. This is done by taking that, again, using your resting heart rate and adding 15 beats per minute. Then you can set that number on your watch or wearable, and it'll alarm. And when that happens, this is when you need to stop and take a break. That is a low number, and that's actually allowed because some people with ME/CFS don't respond appropriately with an increase in heart rate. So we're trying to protect those people, but you can change that number. You can adjust the number based on your symptoms. Also, some people, what they'll do is when they start to get those early symptoms like the shortness of breath or the fast heart rate, they'll look at what their heart rate is and then subtract 5 to 10 and use that as their alarm. Again, you can come back and look at these instructions for that. So what do we do? So if a person develops PIM, what can we do? Life happens. Despite our best efforts, PIM may occur. The patient sometimes overestimates their energy capacity, or they have to make a choice to exceed their capacity due to work requirements or family needs. So once this occurs, one of the most important things they can do is not try to fight through it. Trying to push through is just going to make it worse. So their physiology is kind of like if you have a dead battery in your car, if you continue to try to start it, it's not going to magically start and go. The same way with your body when you're in PIM. This is the time to rest. And when I talk about resting, I'm not talking about the way healthy people rest. If I rest, I'm just going to go lay down on my bed and 20 minutes I'm back. What I want people to do is to really reduce their sensory input. I like for them to use earphones. If it's possible for them to get in a cool, dark room, use an eye mask, that's really helpful. Again, those pneumatic compression boots can be helpful for people. Relaxation techniques. What I don't want them to do is to get too, I want you to rest and I want you to do the relaxation, but if we start doing a lot of chores while we're resting, then it's not rest. Sleep management is very important. As I said, people who are in PIM really struggle with being able to sleep. So this is where providers can help with the typical things they use for sleep management. Also, even consider diet considerations. Softer foods, things that are bland, kind of easier to digest is one way to conserve some energy. Just minimize the steps that they're taking and that kind of thing. Now, there is some off-label medications that we can use. One of the ones I like is low-dose naltrexone, and I actually like this in general for ME/CFS anyway. It's a great drug. It's one of my go-tos. It helps to modulate microglial cells. Again, remember that does have something to do. They have found changes in activation of microglial cells when patients are in PIM. And so this has been seen to help people with brain fog. It also helps people, seems to be reducing their time in PIM. I also find it helps fatigue and pain. So again, that's a drug that has kind of multi-purpose for me, and so I like that. It also is a mild mast cell stabilizer, and so I find that to be helpful. Low-dose benzodiazepines can be helpful. Again, it's also a mast cell stabilizer and can help the person reduce their autonomic overdrive that's occurring in PIM. So that can be helpful for our patients. Dextromethorphan. Yes, I'm talking about the cold medicine. Dextromethorphan, used in standard doses, can act as an NMDA antagonist, and it's postulated that it downregulates and suppresses microglial excitability, and it has a neuroprotective benefit. I've seen it used in different ways. Some people use it every day. They may take 1 or 2 a day. And then I've also seen it more as I know I'm having a wedding coming up. I'm going to take it a few days before, through the wedding, and then a few days after. What I really don't want patients to do, though, is go, hey, I think I'm going to do, I'm going to really push and do a lot of things. And I'm going to take this first. That has not been effective in my patients. So I don't want them doing that. So I'm going to real quick tell you about this patient. So this is a 20-year-old. I want you to see a picture of a person who had PIM. So this is a 20-year-old who before COVID was a full-time college student. She attended in person, and she had a part-time job, was doing really well. She got COVID and ultimately developed long COVID. She really struggled, had some problems with POTS. She had a lot of headaches and had a lot of episodes of PIM. And so she came and saw me, and we worked on everything. And she she was living with her parents. She wasn't working, but she was attending school part-time on at home. It was on an online basis. And so she had some kind of ups and downs, but was doing pretty good. We had her in a pretty good place. And at the end of this semester, she had to go in and take her exams. And we talked about it. We talked about how she could do it more safely, but she really wanted to go and prove that she could do it. And so she studied for exams using cognitive energy. She drove to class, that the sun, she had to drive through traffic. So she had some environmental stimulation. Then she had to park in a parking lot that was a pretty good ways from her class. So she had physical exertion, and went in, took the test, came home. She said, I did pretty good. I felt a little bit irritable, and I found that I was frustrated because my mom was talking to me about it, and I felt I couldn't follow the conversation. That was her first clue. But she went in her room, watched some TV, read a little bit, and went to bed. And she said, I woke up the next afternoon. It took, she didn't wake up in the morning. She woke up in the afternoon. She said, I felt like a truck had run over me. I felt like I had the flu. I hurt all over. My headaches were terrible. Every time I stood up, I felt dizzy and lightheaded. I ended up having to stay in bed a lot. So she ended up mostly bedbound for a couple of weeks. And then it took her 2 to 3 months before she was able to return to her previous baseline. And in retrospect, we discussed this. And if she has to do this next year, she's going to have someone take her to the school. She can, get accommodations where she maybe can take her tests in a room by herself, and maybe perhaps take one day and one another day. And we can do some modifications and pacing to see if we can prevent something like this from happening. So now I want to turn our attention to dysautonomia. And dysautonomia is an umbrella term referring to dysfunction of the autonomic nervous system. And I'm going to focus on orthostatic intolerance. It's quite common in ME/CFS. There was a study done by Van Kampen and others, and they looked at cerebral blood flow. And what they found was that about 90% of adults with ME/CFS and almost 100% of adolescents with ME/CFS had some orthostatic intolerance. So this is something that you want to screen all of your patients for that you suspect have ME/CFS or long COVID. And it's a great target for management. It's one of the reasons for poor quality of life, and so it's something I really like to address. So orthostatic intolerance refers to a group of conditions that simply symptoms get worse when they stand up or they sit up with their feet on the ground for a long period of time. In normal, or not necessarily for a long period of time, but when they stand or sit. And it's improved when they lie down. In normal activity for everybody, when you stand from a supine position, you get a shift of your blood of about 500 to 750 mils into your lower extremities and your abdomen. In normal people, there's a quick response with your heart rate goes up 10 to 20 beats per minute, and you have constriction of your blood vessels. Blood goes back to the brain like it's supposed to, and everything is back to normal. This occurs in about a minute. However, symptoms can occur when this adaptation process does not function properly. So some of the symptoms are secondary to the lack of blood flow to the brain. These include lightheadedness, syncope, impaired vision, fatigue, muscle pains, brain fog, decreased attention, and headache. The other symptoms are related to the activation of the sympathetic nervous system. And these symptoms are similar to a person being in fight or flight, or it is like you're in fight or flight because it's because of the excess norepi and epinephrine that get released. But they have palpitations, shortness of breath, anxiety, tremors, sweating, nausea, abdominal discomfort, and chest pain. So when we evaluate a person for orthostatic intolerance, I have two really quick tools that I find really helpful. One simple tool is to ask about HUA, which stands for hours of upright activity in a 24-hour period. In normal healthy people, that's 14 to 17 hours. In chronic illness, it's an average of 10 to 12. In patients with ME/CFS and long COVID, it's 0 to 7. And again, this is a really quick way of getting a quick picture of their dysfunction. We also have an orthostatic intolerance questionnaire that I use. There are questions that assess symptoms, and then there's a set of questions that kind of give you how much it's impacting life. Basically, it's a 0 to 10 scale, with 10 being the most severe. And I'm just going to show you a picture of that. This is what it looks like. And as you can see on the right side, the numbers get bigger as you go to the right. So a lot of times I'll pull these papers out of my paperwork that I've asked people to fill out, and I'll look at the HUA and I'll look at this. And you, again, if you see a bunch of 10s and you see a HUA of 4, that gives you a good picture of what's going on with the patient. So there's some additional questions you can ask that kind of go along with that orthostatic questionnaire. Do you have a hard time shopping, standing in line? Have you ever fainted? Do you hate hot weather? In addition, don't forget about your medical training, right? The etiology of orthostatic intolerance is huge. There's many things that can contribute. Don't forget about those. PEs, heart disease. There are drugs like, tricyclics, diuretics can aggravate orthostatic intolerance, diabetic neuropathy, adrenal insufficiency. I had a patient early on in COVID. Who had COVID a few, 3 or 4 months prior. He was very fatigued and sounded all in the world like he had ME/CFS, and his orthostatic intolerance testing was very positive. Turned out he had adrenal insufficiency. So, don't forget to get your labs and do your due diligence in looking for other things as well. So there are several types of orthostatic intolerance syndromes that are defined and can be tested for. And I'm just going to mention some of these. And the thing of it is, a lot of the treatment is the same. It's a dysfunction of the autonomic nervous system, and they manifest sometimes in different ways. So orthostatic hypotension is sustained blood pressure reduction of 20 millimeters of mercury systolic or greater, or 10 millimeters of mercury diastolic within the first 3 minutes of upright posture. There's also delayed orthostatic hypotension. This is the same, it just occurs later than 3 minutes. We also have POTS, postural orthostatic tachycardia syndrome, which I bet a lot of you have heard of. It's one of the more common syndromes of orthostatic intolerance that we see in ME/CFS and long COVID. It's what happens is it's more related to the blood pressure response that occurs. And these patients will have, when you do the lean test that we'll talk about, you should have reproduction of their orthostatic symptoms, an increase of heart rate of 30 beats per minute within the 10 minutes of the test, or if they achieve a heart rate of 120 or greater. Now, if the patient is between the ages of 12 and 19, then a heart rate increase of 40 is what is required. Then there's also inappropriate sinus tachycardia. This is when the person has a heart rate of 100 at rest. These people also have coinciding POTS, and the symptoms are very similar. There's orthostatic hypertension, which is when there's an increase in systolic blood pressure or diastolic blood pressure. Again, 20 and 10 for those two numbers. The one I really want you to pay attention to, though, is this last one, low orthostatic tolerance. And this is when a patient has presence of OI symptoms in the absence of heart rate or blood pressure changes. And patients will come in, they'll answer that questionnaire, and they'll have, numbers on the right, 8, 9, 10s. They'll have a HUA, that's lower than 7. They may have a HUA of 3 or 4. You do the lean test, and they look pretty terrible, but their numbers are okay. And I'm afraid, unfortunately, some of these people have been written off. Your numbers are fine. There's nothing wrong with you. There can't be anything wrong with you. Well, Van Kampen and others, Dr. Peter Rowe was involved with this study. What they did is they took a group of people, again, ME/CFS, and healthy controls, and they did a heads-up tilt test. And while they did the heads-up tilt test, they measured cerebral blood flow. And what they found is that healthy subjects had a reduction of cerebral blood flow of 7%. When they looked at the patients with ME/CFS, the patients who met criteria for POTS had a decreased cerebral blood flow of 29%. In addition, these patients with low orthostatic tolerance who didn't have any real number changes had a decreased cerebral blood flow of 24%. So they clearly had something wrong. They just don't have those numbers. And what my thinking is they have that dysfunctional adaptation response. They aren't adapting with some sort of response. They just have the problem with the blood flow. So I've been talking about this lean test, and there's going to be a QR code for you to look. You can download this and look at all the directions, but I'll give you kind of a brief overview. So what we do is we start with a patient lying down in a dark room, no phone, no conversations. And so they lie still for 15 minutes. We go in, take their heart rate and blood pressure supine. Then we stand them, as you can see in the picture, head and shoulders are against the wall, and the legs are the feet are planted on the floor 6 to 12 inches forward. So they're leaning against the wall. I don't want them to move their legs around. I don't want them to fidget. We'll ask them questions about their symptoms, but we don't have conversations. And so we start taking their heart rate and blood pressure, pulse ox every minute. And we measure those findings, and we do that up through 10 minutes. And Dr. Peter Rowe out of Johns Hopkins looked at some data and found that about 50% of people are missed if you don't go at 5 minutes, you still miss 50% of people. So it's really important to get the full 10 minutes if you can. So you also look for skin changes and perfusion changes. This is my patient that I told about you earlier. He is bedbound now, but when I did the lean test on him, he wasn't quite so sick. And you can see the acrocyanosis. You see his mom's hand in the picture to the right, and you can see that difference there. And he did test positive for POTS. So what can we do about this? So the first thing is non-pharmacological measures, avoid triggers. Heat really makes this worse. So avoid heat as much as possible. Hot showers are not their friend. Get a shower chair. Avoid dehydration, avoid standing in place if that's possible. If you do have to stand in place, doing some isometric exercises, crossing your legs, fidgeting, things like that can be helpful. Make sure the patients aren't on drugs that can make their symptoms worse. Then the next thing we want to do is to increase their intravascular volume. Remember, they're blood pooling, and our patients have a hard time getting that blood back into the intravascular space. So we want to add sodium and water. And we want to add sodium water in equivalent ratios. If you just do the water and don't do the salt, they're just going to end up in the bathroom a lot of the time. And we're not really going to keep that water where we want it. So I usually do, and I give a range of what I'd like for them to get: 2 to 4 liters of water, 2 to 4 grams of salt. And again, it depends on the person. If you have an older person and they have a little bit of hypertension, I'm not going to ask them to do the 4 liters and 4 grams of salt. But if they're a younger person, maybe they're a 20-year-old male who's 6'4", I'm going to want him to try to get the 4 liters and 4 grams. When you first see a patient and they haven't been treated for the orthostatic intolerance, it's very hard to get them to do this orally. A lot of times they'll have nausea, they're not absorbing things well because of their orthostatic intolerance. And so sometimes I'll start with IV fluids if we can get that arranged. And I'll do 1 liter of normal saline, do it over an hour or two. And usually with 1 IV, I can get 3 days of that done. And I try to do it for 3 or 4 weeks. Then in the meantime, I'm encouraging them to increase their oral intake, and we will start a medication and do that for a few weeks. And then we can usually stop the IV fluids and they can continue as doing it with oral ingestion. So compression clothing can help assist the skeletal muscles to increase venous return and minimize venous pooling. Full compression is superior to abdominal compression, which is superior to leg compression. But any compression is better than no compression. I really struggle with my patients. I live in the South, and it's extremely hot here. And especially in the summer, I have a hard time getting patients to do this. But if you can get them just maybe to do an abdominal binder, that can be helpful. And you can go from 20 to 60 millimeters of mercury. Again, 20 to 30 is a little more realistic. So here is a list of medications. There's the QR code that will be provided to you. And I'm not going to go over all of these. I think it's a little bit overwhelming to think of so many different options. So I'm going to give you some of the more common ones that I use, and then you can always refer back as you're feeling, as you want to expand what you're doing. So fludrocortisone, this is a mineral corticoid. It promotes resorption of sodium. It does cause loss of potassium, so you want to watch for that. It helps fluid stay in the circulation by helping the kidney to reset the definition of euvolemia. You need the patient to fluid and salt load. If you don't have that on board, it's not quite as effective. A common side effect is headache that can occur in the supine position. Also, I have rarely seen it cause depression, so that's one thing I do like to be sure and warn my patients about. And if they stop it, it resolves, but just for them to be aware. Also, I particularly think of this drug in patients with orthostatic hypotension, and I avoid it in patients with hypertension. It is okay to use in pregnancy. Then the next common drug that I use is midodrine. Midodrine is an alpha-1 agonist. It increases both arterial and venous tone and will increase their systolic and diastolic blood pressure. I think of using it in people who have a hard time standing. So if they tell me I really have a struggle when I do a shower, a struggle when I'm in line, if they have rapid temperature changes, if they have facial flushing, those are the people that I think about. And of course, people with low blood pressure. Two side effects to be aware of. It can cause some pseudo-neurological sensory side effects. So the patients will say, I feel like my head's kind of creepy crawling and kind of goosebumps on their skin. But this usually resolves in a week or so. So if they are able to tolerate it for a little bit, it usually goes away. The other thing is it can cause supine hypertension. I usually see this more in older patients, but it can occur. So I don't want you to take it at bedtime. I don't want you to take it and immediately go and lie flat. They can sit in a chair and they can recline a little bit, but just don't want them to lie flat. Pyridostigmine is another popular drug. Now, this is used off-label. It was developed for myasthenia gravis, and it inhibits acetylcholinesterase, so it reduces the breakdown of acetylcholine at the neuromuscular junction. It has three actions that are helpful. It increases tone, it increases blood flow return to the heart, and it reverses arterial shunting that's mediated by small fiber neuropathy. And it's this drug, I find it for some people it really makes a difference, but you got to find the person that can tolerate it. It has a lot of GI effects with cramping and diarrhea. It can cause muscle fasciculations. Now, these are not painful, they're not dangerous. However, they're frightening if you don't know they're coming. So just be sure and let your patients know that this may happen, so you don't get a panicked text in the middle of the night, which I might have had happen to me once. So just be sure and let them know. Now I know to do that. It can also cause increased sweating, salivation, and tearing. I consider this in patients who have slowed gastric motility, constipation. I also use it in patients who complain of weakness. I do, of course, avoid it in patients with chronic diarrhea. It's also been used in pregnancy for years for myasthenia gravis, so considered safe for our patients who are pregnant. Beta blockers is another popular drug. We use this a lot in POTS, sinus tachycardia, and patients with sympathetic overdrive symptoms. I use it sometimes in people who have insomnia, just because usually that a lot of times that is helpful if they have those if they wake up startled or if they have bad dreams. I'll try to use it for that. I prefer the second generation beta blockers or the first generation beta blockers. Third generations avoid, it causes vasodilation and will make symptoms worse. Some of the side effects are fatigue, dizziness, bradycardia, and asthma symptoms. And the first generations are more likely to cause that. Of note, I have found that a lower dose tends to help my patients better than going full-blown with a higher dose. There's a study by Vanderbilt, and they used 10 milligrams of propranolol TID, and that was what they found was the optimal dose in their study. So now I'm going to move to mast cell activation syndrome, last but not least. The first case reports of mast cell activation syndrome were described in 2007. So this is we've been talking about it since the 1980s, but a fairly new disease when you think about medicine. I did not hear about mast cell activation syndrome when I was in medical school. I didn't hear about POTS either. Or MECF. Truthfully, none of this. None of this was taught to me in medical school. So mast cell activation syndrome has an estimated prevalence in the population of 17%. It is thought to occur very frequently in people with ME/CFS and long COVID. I could not find any numbers that I felt confident using, but I will tell you that in my practice, it affects a very high number of people with ME/CFS and long COVID. The heightened incidence is likely due to a combination of prolonged immune activation, chronic inflammation, viral persistence, and the inherent sensitivity of mast cells to viral infections. The complex interaction can cause mast cells to remain overactive, leading to the wide range of symptoms that we see in our patients. So mast cells are a white blood cell. They're produced in the bone marrow. They are located in the environmental interfaces where your body interacts with the outside world, your nose, your eyes, your mouth, GI and GU tract, respiratory tract. It also surrounds your blood vessels, nerves, and connective tissue. So it's all throughout your body. They are involved in allergy and anaphylaxis, wound healing, angiogenesis, immune tolerance, vascular permeability, and it is a defense against pathogens. So there are two major categories of mast cell disorders. We are focusing on mast cell activation syndrome. This refers to a group of disorders with diverse causes and is the result, at the end of the day, of excess production of mast cell mediators. And there are 390 mast cell mediators, so that's a lot of things to be overproduced. So what happens is when a trigger or an allergen is presented to a mast cell, a chain of events occurs. The mast cells become activated and these mediators are released. Just some of examples of the mediators are histamines, leukotrienes, prostaglandins, heparin. This is the one that causes the increased bruising we see in our patients, cytokines, and tryptase. Again, there are over 390 mediators that have been identified. These mediators can then trigger an inflammatory cascade by signaling distress signals through the nervous system. So a local reaction can cause a multi-system response. I have seen patients treated for their GI mast cell disorder or for their GI symptoms caused by mast cell, and then I've seen it treat their seizures or their non-epileptic seizures.
Dr. Hoppers, just to
Yes.
say, if we can wrap it up in like max 5 minutes, that would be perfect. So
Okay.
leave time for
I'll start
questions. Thank you.
talking really fast. Okay. So many symptoms can occur. You can have anaphylaxis. There's GI symptoms. There's skin symptoms with rashes and urticaria. We have respiratory symptoms, wheezing, asthma, rhinitis. You can have flushing. Also, even weird symptoms like osteopenia, osteoporosis, dysmenorrhea. So here's just an example. This patient on the right, she had a Band-Aid after a stellate ganglion block, and this was the rash that she developed. I see this rash frequently, so if you see this, this is a clue. Also, dermatographism can occur with your patients. There's all sorts of triggers. Triggers can be pretty much anything. Heat, cold, temperature changes, pressure, vibrations can do it. Multiple drugs. If you notice that a patient has 6 or 7 allergies, that's a clue. Venoms, exercise, food and beverages, you get a lot of GI symptoms. So there's lots of different triggers. How do you diagnose it? If they have episodic symptoms that occur in 2 or more organ systems, and we've kind of gone over those symptoms that occur already. If they improve after treatment, and we'll discuss at the last what treatment we can use. If they have elevated labs. Now, let me just tell you really quick, these labs are hard to do. They are hard, the mediators are labile, heat sensitive, and they must be processed, transported, and collected in a very specific way. And this is frequently done incorrectly. So I'm just going to let you know that if you have a patient with negative lab testing, it does not mean that they 100% do not have mast cell activation syndrome. It's very hard to get these labs positive. Caveats for testing: when you send them for testing, make sure they're off all anti-inflammatory medications at least a week before. So NSAIDs, creams with NSAIDs, vitamin D, E, and C as well. There are a lot of pain syndromes associated with mast cell, irritable bowel, sickle cell disease, migraines, bladder or interstitial cystitis are some of the ones that can be connected. Again, we want to avoid triggers. Diamine oxidase can be helpful for people who have histamine sensitivity in their diet. At the end of the day, I like people to start with a low processed food diet. In the US, at least, we have a lot of processed foods that are very unhealthy. Don't eat them. Mast cell activation treatments, and this is my next last slide. H1 and H2 blockers can be helpful. And I also add leukotriene blockade with montelukast and zafirlukast. Be aware that there's a black box warning about depression and suicide with that one. So I'm very careful with who I give that to. Here is a list of mast cell stabilizers and their doses. I like cromolyn sodium, ketotifen. You can also use quercetin, vitamin C, luteolin, vitamin D. So that's something you can even just do over the counter. As I mentioned before, benzodiazepines and naltrexone can be mast cell stabilizers as well. And again, you'll have this list for you. So just to recap real quick, treating patients with ME/CFS can be daunting. They have a very serious illness. It's complex. It's a multi-system illness. Their symptoms wax and wane, and you have to make frequent adjustments. But if it's hard for you, just think of how hard it is for the patient. Please make an attempt to see patients and make an attempt to help these patients. As of now, there are not enough people who are doing this, and they're just left out without any health care. And so I really, really appreciate your time and attention today. Thank you.
Thank you so much, Dr. Hoppers. I'm somehow, one moment, starting my video again. Let's stop the sharing. Okay. And I think I'll bring everyone okay, I think everyone can see everyone now. So please feel free, everyone, to turn off on your cameras if you want to. I think Dr. Hoppers will be very happy to take questions from anyone at the moment. You can put them in the chat, you can just raise your hand, you can just speak, whatever you like. Some of you might be muted, so just yeah.
Dr. Hoppers, how do you approach trying to break down where to start with the patient when it's this multi-system illness? How do you decide where to start?
Okay, so and I try to think of this question from my standpoint of view and from people who are primary care. So let me full disclosure, I was a primary care physician, and when my daughter got sick, I found there was no one who would not only see her for ME/CFS, but she was a child. So there just was nowhere to get anyone to see her. And I learned I had to learn how to I had to learn how to do it, take the information to her primary care to get help. So I have that viewpoint. Now I have the viewpoint from what I do as a person who sees patients with ME/CFS. So I have more time to see the patient. So I'm going to give it to you from the standpoint of a primary care because I know you have time limitations. But one thing that I do is I have a lot of questionnaires that I give patients so that I can review those before they come in. For instance, the Orthostatic Intolerance questionnaire, the HUA questionnaire. That gives me a quick idea. Okay, it looks like they have a lot of problems with orthostatic intolerance. Then I'm going to focus on that and I'll get the information that I need, and then I'll have them come back and we'll talk about starting something. I like to break it down into their comorbidities. I look at the global picture, but there's not really anything that you can say, here's a medication that will help ME/CFS. But there are medications that will help orthostatic intolerance, which is involved in your ME/CFS. Or here are medications that will help MCAS that is driving your ME/CFS. Or if you aren't getting restorative sleep, how can anything get better? We've got to help you with your sleep. I generally start with what's bothering them the most. If they say, and I'll ask them, what's bothering you the most? And some people will say it's the fact that every time I stand up, I feel like I'm going to faint. I can't think. I can't get around because of that. Then I'm going to focus on orthostatic intolerance. I have some people that They work at home, they work remotely, but they work on the computer, and they are more disturbed because they have cognitive problems, and those cognitive problems are interfering with their ability to put food on the table. So I'm going to do more of addressing their cognitive abilities. And I didn't address that, but that's in this talk, but that's where I'm going to go next, or where I'm going to go first. But when I do a first visit, I do a lot of surveys. I get the lean test, and I get labs just to make, to rule out other possibilities. But it just depends on what symptoms are bothering them the most. And a lot of times too, I kind of want to get the most bang for my buck. I want to gain their trust and help them, see that there is a light at the end of the tunnel. If there's something, if they have POTS and their heart rate is routinely getting to 130 every time they stand up, and I give them a little dose of propranolol, and all of a sudden, they feel a lot better, then they go, oh, okay, something can be done. And that's encouraging for the patient. The other thing is we have to address PIM. If they are in PIM, and some people, it's obvious with my patient that I talked about that went and had her test, she's bedbound for 3 weeks. But we also have PIM or situations where people are kind of in what we call rolling PIM. So, they push every day, go to work, they come home and they're exhausted. And they sit on the couch or sit in the bed or wherever for 3 or 4 hours, get a little something to eat, go to bed so that they can get up and go to work the next day. Then on Friday, they're miserable, and Friday, Saturday, Sunday, all they do is rest so they can get up and go to work again. So they're living to work. And so if we can find ways to help them pace and do some things, maybe work accommodations to get them some time off so they can do some recovery, again, that's a good place to start. Because if they're in rolling PIM, a lot of what I do for them is just not going to be as effective, if effective at all, because they're in PIM.
Thank you so much. If anyone else want to jump in, because I have like a million questions. I was wondering what your approach to antivirals was at the Bateman Horne Centre, if you used them at all. And I know there's a little clinical trial you're running. Any thoughts on that? Because I know it's a bit of a controversial one. So yeah, grateful for your thoughts.
Mm-hmm. Yes, I do. I do. And again, so one of the things I tell my patients is I have a huge toolbox. I have all sorts of things in my toolbox. I have things in my toolbox I like to use first, and I save some kind of for the end. That's not one I start out with, not typically, unless a patient has, if I have a patient who says I've had shingles in the last or I've had shingles twice in the last 6 months. I get cold sores frequently. I feel run down a lot. I've got that sick feeling, evidence of herpes or what have you, then that person, I'm more likely to start antivirals sooner. I have some patients where I just go down the list of my toolbox, and sometimes it's way down on the list where I find the thing. I had a patient not too long ago who has been doing pretty good. We treated her for her orthostatic problems, and I think she was on LDN. She was doing pretty well, but then she got sick, went to urgent care, and tested positive for mono. We put her on antivirals, and she's actually improved overall and done really well, and we're keeping her on those. So again, it all depends on the patient and what would clue me into doing that, but I do use them.
Fantastic, thank you. Again, I'd like to give people a moment to see if they have something to say.
I want to say something, please.
Yeah, absolutely.
Okay. I got MECFS when I was 41, and some of the symptoms were mistaken for the brain. גיל המעבר, נו, המוח שלי נדפק.
Do you want to say it in Hebrew and I'll translate?
גיל המעבר.
Menopause change?
Yeah.
Menopause change?
So it was mistaken for premenopause because the gynecologist said premenopause symptoms can occur 10 years before the menopause. And when I got into menopause, I had terrible 4 years. And only when I got the HTR, the hormonal replacement treatment, then I realized what symptoms were related to the menopause. And it was a very big change. And since I don't get doctors that I can work with, I don't know how to combine it with the menopause factor.
Well, one thing is, it's complicated. When you have a patient, especially with long COVID, I notice this more with long COVID because with ME/CFS, it can occur at any time, but frequently, my patients would be younger patients with less medical comorbidities because, they were getting mono when they were teens, and then they would get ME/CFS. With long COVID, that sort of changed because everyone, so many people got COVID, then so many people got long COVID. My oldest patient, I believe, was in his upper 80s, actually. And the funny thing, he is one of my patients that completely got better. And so it doesn't mean that they can't get better. It just means that you have to think about a lot of other things. He had orthostatic intolerance, but it was really interesting trying to navigate that with his other cardiovascular problems. But one thing, again, that's so important is to identify any other issues that could be causing the problems. Is it ME/CFS plus other issues, or is it, oh, wait, it's not ME/CFS, it's other issues? The difference is post-exertional malaise. That's where I really try to identify if the person has ME/CFS or not, is do you have post-exertional malaise? And that is a good way for me to determine the difference. But as far as the symptoms for being in menopause, I would absolutely treat the menopause. If you have diabetes, I absolutely want your diabetes under control as best as possible, because how much is that contributing to everything? If your sugars are out of control, you're surely going to not have your ME/CFS under control either. So I try to address any other issues, or have their primary care address the other issues that could be contributing. Does that answer the question? I'm not sure I had if that was the question you were asking. I want to make sure I'm answering.
I think what I was trying to say is that the symptoms of premenopause or menopause are so similar to ME/CFS. I have both. I probably have other issues as I get older, but what I was asking is about the collaboration. לא, המוח שלי לא עובד.
תגידי בעברית.
בתחומי רפואה, כאילו בין...
Talking about the collaboration between different specialists, are there like any gynecologists or like and so forth that know about ME/CFS? Does that even happen? Is that a thing? Yeah.
We would hope. It's very hard, and I try to help coordinate care with those providers. And incidentally, hormone changes can impact post-exertional malaise and MCAS for sure. And anything, your ME/CFS and PIM symptoms can absolutely be contributed to by other illnesses. So with my patients, I try, like if I try to make sure that I work with their primary care regarding what they're using, what they're doing. For instance, certain birth control pills can aggravate MCAS and can aggravate orthostatic intolerance. So I'll send a request, hey, would you avoid these particular medications? I mean, you have to find someone who will do that. You know, I hate to put things back on the patients, but sometimes patients, who most cares about your care? You. And so, you know, if you can bring some information to your provider, that can be helpful as well. And I hate to say that because I hate that patients have to do that, but it can be helpful.
Thank you very much.
You're welcome.
I'd love to ask you a bit about the whole exercise conundrum, because I think when we talk to doctors, that's one of the main things we get pushback about. Them not believing us that exercise is bad for us. And some of them are doctors that have been researching this area for a long time as well, so it's hard to argue with them. And yeah, we'd love to hear kind of your thoughts on that.
It is so difficult. It is so difficult. And the only way I know to combat that is to kill them with science, not literally, but, you know, show them the science, show them these studies that have been done. You know, I know that I sound like a broken record. I tell people about this all the time. My family they start to roll their eyes when I meet someone that I don't know and I'm telling them about the science of PEM. They're like, stop telling everyone about this. But just spreading the word. The Bateman Horne Centre is working on a paper to talk about PEM. We have videos that Dr. Yeoman and Dr. Bateman have done that are excellent videos. That's something that patients can share with their providers. They're short, they're about 4 to 7 minutes long. They're 7 videos. You can listen to them in your car, and they're incredibly informative. And, you know, gosh, someone asked a question the other day on a talk, how do you tell the difference between this and a person with somatoform disorder? Well, I've never seen a patient. If I'm going to have a somatoform disorder, I want some sort of what's the benefit for me? I want off work. I want off, you know, I don't want to have to do something. Patients with PEM aren't usually going to their doctor. They want to know how to increase their activity. They're not asking, how can I stay in bed longer? They want to know how to do more. Again, sharing with them like the videos. Talia, do we have a one-pager on PEM? Because if we don't, I could create that. But we need, I have some one-pager things on the website because I know that providers are busy. And if you can take them something that's one page, I think that they might read it. And so we try to just make them really succinct and to the point. Here's the key things, but sharing with them the science that there's mitochondrial issues, there's oxygen extraction issues, aerobic capacity is decreased. It's been done on validated tools. And, you know, that's the bottom line. And I'm trying to think if there's any other way to convince your provider and also your family. You know, the family sometimes is who you have to convince, and getting them on your side and getting them to help you be creative in how to reduce your activity levels. And not your activity, just reduce your energy consumption. Sometimes you can do things, you know, if you use I tell my patients, if you use a shower chair, you may gain a minute if you, at the end of the day. If you, you know, reduce your sensory input while you're reading, you may gain another minute. And maybe by the end of the day, you've gained 10 minutes to do something you enjoy, or be able to eat dinner with your family, or do something that is meaningful to you. So again, trying to, the things that really, you know, whether I sit or stand to fold my laundry, sit and save that energy and use it for something else.
Yeah, thank you very much. Thank you very much. I mean, it's very intuitive and clear to us, I think, but somehow, even after reading about post-exertional malaise, some people say, okay, but exercise has benefits, and kind of letting go of that paradigm that exercise has benefits, I think has been hard for some people.
at the end of the day, you only have so much energy. And you can use it, you know, if you have enough energy to go walk for 15 minutes, great. But then the rest of the day, you can't do anything. What have you gained? And so, again, just trying to educate them, and we're certainly doing everything we can to do that. I will say that I am seeing some encouraging things in that area. I've seen a lot of papers coming out. The Bateman Horne Centre is working on several issues behind the scenes to try to get people educated, and in a big way. Also, I had a thought that I just forgot, but you know, there are resources. Again, take a video to them. You know, they don't like that, but take it anyway.
I would just add that if you're able to find a physical or occupational therapist who really understands what's going on with ME/CFS, they can be one of your biggest allies. Not only professionally in helping to support patients with, you know, low energy thresholds, but also in kind of having those conversations. A lot of the work that we've shifted towards is working with PTs and OTs, because they help the patients navigate their everyday energy utilization, not just that 10-15 minute window with their primary or specialty care provider. And they are the ones doing the CPET testing. They're the ones seeing how that replication of energy the next day is just not able to be there. So I don't mean to keep just throwing a whole bunch of resources in the chat, but I'm going to throw one to our rehab page, because they have specifically created resources and tools that can kind of speak to that a little bit better.
Fantastic. Thank you, Talia. Okay. Unless anyone has any kind of last questions or remarks, I'd just like to thank again Dr. Hoppers and Talia from the Bateman Horne Centre. I really also just want to add the extent to which the Bateman Horne Centre is a beacon of light in the ME/CFS world. Really, you are. Kind of brings me to tears when I think about the work that you do. So thank you again so much for being here. Us patients are going to stay now after, in case anyone wants to have a conversation with us. But otherwise, we are done for this evening. Thank you so much.
Thank you for having us.
Thank you very much.
Thank you so much.
Thank you.